the name of this specimen? It's a colon. Yeah, awesome. Picking up from what Will was talking about last week, can anybody tell me what we're looking at here? Tinea, awesome. So yes, this is a subtotal colectomy specimen. Anatomically, we've got some really great features, but we've got everywhere from the terminal ileum, moving all the way down to the rectum, okay? And talking again from last week, we can see some of these anatomic structures where you've got the upper third of the rectum up here now, which again has that posterior radial margin. And then as you come down a little bit further, you start getting a wider margin. And once you're down into the rectum, you've got a circumferential margin, which here you can see is painted blue. Now, what we're going to do is going to turn this over and show you this specimen.
So with that, I'm going to yell from here. If it sounds like I'm yelling, because I am. I'm going to put up the poll. First poll of the day.
First poll of the day.
So what do you see in this specimen? Most likely inflammatory pseudopolyps, adenomatous polyps, hyperplastic polyps, hamartomatous polyps, or a parasitic infection. And we'll share the results. There we go. So yeah, I think most likely, as people have identified, this is probably an adenomatous polyposis. You can get this degree of inflammatory pseudopolyps, but they're not going to be this well formed. And can someone in the chat tell me when you would see this degree of inflammatory polyposis? Yeah, for sure. Really bad IBD, right? Anyone more favored versus than the other IBD? Which one? Yeah, absolutely. So UC, you can get this bad of a polyposis of the inflammatory type. Hyperplastic polyps, shouldn't this be numerous? Neither should be hamartomatous polyps. And schistosoma, as far as I can tell from the literature, has only been described once, appearing as a polyposis. So yeah, so adenomatous polyps is what we're seeing. And can someone in the chat tell me what they think this type of polyposis might be? Thank you, everyone. So yes, FAP. So I'll switch over to Brian.
Awesome. Yeah, a great discussion, guys. This is indeed an FAP case. I do want to just highlight a couple of these polyps and show you a couple of examples of, I guess, descriptors for polyps. And so I'm trying to find a good example here. Okay, let's get that into focus. So you see some of these polyps that are in the middle of the center of the screen. So these are good examples of what we would call a sessile polyp. And these are polyps you can see that are different from the surrounding mucosa. Right? There's a delineation, but they're flat on the mucosa, as opposed to a pedunculated polyp, which has a nice stalk to it. So you can see this nice polyp on top, and then underneath it, there's a stalk to it that would describe this as a pedunculated polyp. So carrying on, you can see that really this whole specimen is carpeted with polyps. Can anybody hazard a guess as to how many polyps there likely are in this specimen? Hundreds, definitely over 100. Thanks, Ariel. And that's exactly the marker that we want to look at when it comes to counting the number of polyps. And so in order for this to be a true FAP case, we generally would want at least 100 polyps. Often in classic cases, you'll see in the order of either hundreds or thousands of polyps which carpet the entire specimen. And you can see from this one, there's well over 100. I mean, even just on the left side alone, there's innumerable number of polyps all the way around. This happens to be a colectomy from a 18-year-old who basically fits the demographics for first case diagnosis for FAP patients. The median age is actually 15.9.
So before we get into that, I'll launch the second poll question while we're on the topic of FAP. What is the mode of inheritance for FAP? So most people got it. It's an autosomal dominant mode of inheritance. I just want to discuss this number of 100 as a cutoff. What does it mean if it's less than 100? What does that have in terms of implications? If someone can just put in the chat. First of all, what is it called and why the 100? Yes, so it's the attenuated form of FAP.
What's the risk of this patient without surgical intervention for him to proceed to getting a carcinoma?
So this is one of the few instances where it's that if you don't have a colectomy, with this early of a presentation, that you have 100% chance of getting colon cancer later on. The intervention is really surgical removal at this early stage before it progresses any further. The attenuated form, there's a lot of, I guess, discussion and in terms of management of what happens when it's less than 100. We've seen numbers of between 20 and 50 where you can kind of just leave and not have a surgical intervention, kind of take an active surveillance type of approach. But really the numbers are all over the place with respect to that. But the key number to differentiate here is that 100. And anything greater than that really predicts for a high risk of getting colon cancer.
So the other important piece just to note is when we look at these polyps here, they're actually no different than any other adenoma that you might find sporadically in any other case, whether it was resected for an IBD or another, colon cancer, that you may actually appreciate them. So kind of burn these pictures in your head of what these polyps look like, because you will find them and stumble across them in other types of specimens as you gross them. So from a grossing standpoint, what we want to do here is count the number of polyps. And you can spend all day and actually count the actual number, but recognizing that we basically need more than 100, you can do an approximation. Part of our protocol, we'll do like a density count of the number of polyps per quadrant. And so we'll say roughly how many are there in the cecum per centimeter square, how many on the right side, how many on the transverse, and then how many down the left side. Again, number of polyps per centimeter square. And so, you can conceivably just do that by, counting off like a 3x3 and then dividing out that by 9 to get a rough approximation. You want to measure the polyps and give a range in size. And so we've got quite a variety of sizes here, from really small, millimeter sized ones to our largest at about, 2 centimeters. And then distance to margins, you want to talk about how far away your most proximal one is to the proximal margin. And at the distal margin, you actually have a number of polyps at that margin. And then from there, in terms of sectioning, you would section through the specimen as if you would any colonic case. And so here for the polyps, any polyps that are greater than 1 centimeter, you want to submit those in total, with the idea being kind of the larger the polyp, the higher the chance of those having invasive components in them. And in this case, we can see there's not a huge number of them that are greater than 1 centimeter. And so conceivably it'd be relatively easy to put through all of these greater than 1 centimeter polyps through in total. I have seen cases where, this was polyps of this size were on the smaller end, and we had more kind of golf ball sized polyps, and that becomes a little bit more challenging to put through all of those in total. And so you've got to be a little bit more selective with your sectioning. But for this case, we're all right. And then as you kind of make your way across the specimen, you want to sample all of these polyps kind of intentionally as you go around through the specimen. In this case, I think I still would take my distal margin on fast, because I do have polyps at the margin anyway. But you could do perpendicular sections and then kind of where the closest ones are, but you end up just doing perpendicular sections around the whole circumference of that distal margin anyway. From there, we will do standard sections of things like appendix, your ileocecal valve, and then lymph nodes. There's a ton of them. And so checking the clinical history, if we knew that there was previous biopsies talking about areas that showed more high-grade dysplasia or actually showed invasive components, that's the part of the colon we would do a little bit more of a thorough dissection for nodes. In this case, what we would do in the absence of that history, we would section this off into the right side, the transverse, and the descending, and then just do a relatively thorough node dissection, maybe finding 12 to 16 nodes per quadrant, if you will. This node dissection, as daunting as that would be relatively easy because the nodes are huge. Then the last part of our protocol talks about a Swiss roll, like a mucosal roll. And the idea is that you're stripping off the mucosa from the submucosa and then making a membrane or like a mucosal roll out of that. So you're increasing the surface area for which you can examine that microscopically. I'll leave the free edge kind of untouched, and then the first, I'd say 2 centimeters and moving into the colon untouched from sectioning, because I want to preserve that strip for the Swiss rolling. And so, for example, we'll just take this piece here on the right side. And what we'll generally do is we'll just score it very gently. And I'm not cutting all the way through. I'm just trying to cut the mucosa from here. Where's my cut? You just score down a little bit. And the easiest way to do this is actually find a pair of blunt nose scissors. I lost my cut. There it is. Grab a pair of forceps. And then just very gently tease away the mucosa from the muscularis, following that plane of dissection. Just basically continue along that strip. Try not to puncture through the mucosa. If you do, that's okay. It just makes some of that tension a little bit more challenging because you want to use a little bit of tension to pull back the mucosa as you're dissecting away. While I'm doing this, Carla, do you want to answer the questions in the chat? What's the first question?
Let's take the easy one, I think. How do you take the margin on FOSS? Fit it all in one cassette.
Yeah, so that's a great question. I would literally just cut this margin off in a strip, and you wouldn't be able to fit it into one cassette. You'd likely have to divide it either in thirds or in quarters, depending on how wide that is. And then those would go on fast into the one cassette. And you would just denote that as, block 3 and block 4 are the distal margin on fast, bisected or whatever, trisected.
The next question is, when you divide the colon into the segments, are you just arbitrarily dividing them into thirds, or are you using anatomic landmarks?
We'll usually use the omentum as your landmarks, recognizing your transverse starts roughly at the hepatic flexure and then ends at the splenic, and that's kind of our dividing markers for dividing into those quadrants.
Remember, folks, really the documentation here is the density of the adenomas. Like, you can kind of measure that from the gross assessment with respect to the actual numbers, and then you kind of give a more accurate, I guess, density measure by using your sampling. You're also, ideally, you don't have any history of any high-risk features, meaning high-grade dysplasia or frank malignancy in these specimens. So really, you're just documenting the adenomas.
Okay, so I've just done a small segment, but you kind of get the idea, right? You're basically using a little bit of tension to pull the mucosa away from the muscularis. You can see what that looks like there. And what I'll do now is I'll dissect off that strip of mucosa, and then just like in making fetal membrane rolls in the placenta, very gently place the mucosa between your forceps. You'll do a roll of the mucosa, basically like that. The trick now is to get a very sharp and clean blade, because the tackiness of the submucosa actually keeps it all together, but you want a nice sharp blade. And all you're gonna do
So if anyone's made cinnamon rolls,
the mucosal roll.
It's the same principle. Okay.
So the idea with this is that you've basically increased your surface area to look at some of these adenomas microscopically. And then the last piece that we'll do in terms of sectioning for this is we will find some part of the mucosa that's a little bit more flat. And I might use maybe here as an example. You can see that there's a little bit less polyps there, but what we'll do is we will carve out, again, another piece of that mucosa, lift it up from the submucosa. But it's a square, let's say about 2 by 2 centimeters. And then that piece of mucosa will go down on fast into the cassette so that histologically you're going to start seeing cross sections. And the idea of that is that it'll allow you to evaluate if there's any smaller kind of microadenomas hiding out that might be 2, 3, 4 clusters of cells big.
Put up a PDF there of the cancer risk associated with FAP. So as you can see there, that it's nearly 100% for colon cancer with varying degrees of percentages.
Yeah, the urine.
Yeah, so can we kindly just make sure that people are muted? The audience there, please, just so you're not popping in and out. So for everyone, which of the following is not an extracolonic manifestation? Share the results. Okay, so thank you. So most people got the right answer, which is cafe au lait spot. So if we can just kind of go down the list. Gastric polyps, very common. Did someone in the chat tell me where exactly in the stomach you'll find these polyps? Yep, so gastric funded polyps. Desmoid tumors, of course, quite common. So we see that a lot here, mostly because we're a sarcoma center, but also from the GI perspective. Medulloblastoma, what's the other name of the familial syndrome that's associated with? Turcotte, yes. Osteomas and chirpies, or congenital hypertrophy, or any ocular type of problem. That's also quite common in FAP, and in fact, part of their workup is an eye exam. Can anyone else in the chat tell me what else are the extracolonic manifestation? I didn't list them out, but there's quite a lot of them. Where is cafe au lait spots usually associated with? Which syndrome? Neurofibromatosis. What is the defective gene in FAP? All right, well, people know this. we'll stop the poll there. And yeah, pretty much everyone got it right. So it's APC, it's a mutation. For the Keeners, what's the gene location specifically? Thank you.
Awesome.
5Q21. I think that's all we have for today. If any burning concerns on how to deal with FAP samples, if not, we want to say thank you once again. Hope everyone has a wonderful Friday and an even better weekend.
Thanks, everyone.